Welcome to our 11th session of our Oxygen Therapy and Critical Care, the case-based series. Today we will be discussing essential emergency and critical care. We have a fantastic panel for you today. Here with us are Dr. Anna Maria Crawford from Stanford University, Dr. Lise Mumfureze, University of Rwanda, Dr. Tim Baker, Karolinska University Hospital, Sweden, Dr. Bryant Shannon, Stanford University, Dr. Karima Khalid, Muhas, Tanzania, and Dr. Fred Meem, Stanford University. So before we begin, as always, just some brief Project ECHO etiquette and housekeeping. Our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for questions and answers at the bottom middle of your screen. Please send all questions through the chat box and feel free to introduce yourself. Please turn on your video if you can and position your webcam effectively to show your face if alone or to capture the whole group. If you have any IT issues, please send a message through the chat to IT Alana, and she would be happy to assist you. The session is being recorded and your attendance is consent to be recorded. Thank you. Today, there is interpretation available in French and Spanish. You do need a new version of Zoom for this to work. Choose to mute. You can choose to mute the English part of the session or listen to both. Translation will be louder than the speaker. If you just click on the interpretation button and choose Spanish or French, that will take you to our interpreters. Great, and with that, I'm going to pass it to Dr. Anna Crawford to begin the session.
Hello, everyone, and welcome. We're very excited to have another session, and today we have some really amazing panelists. I'm going to start sharing my screen so that we can see the case-based discussion, which is found on the Learning Resource Center. We'll put the link to the Learning Resource Center in the chat box, but this resource is available to all. It's free and open access. A disclaimer is that these discussions are not intended to replace clinical judgment, but are aimed to increase discussion amongst care providers from variably resourced settings. And also want to let you know that all the information, the LRC is free from advertisement money. So we want to have no conflicts of interest. So today we're going to talk about a 61-year-old man who presents to a local emergency room with shortness of breath, dizziness, and diarrhea of 7 days duration. And we're going to use this case to highlight essential emergency and critical care. Instead of learning objectives, we like to have practice change objectives to empower our learners to make changes in their own practice to improve the safety and quality of care that they provide. So our practice change objectives today, we want to explore acute care, critical care, and intensive care, and define these three terms as sometimes as a source of confusion for providers. We want to list the domains across which acute care occurs and recognize that critical care is a continuum and can occur in many different places, not just an intensive care unit. We want to define essential emergency and critical care and recognize the two key domains, which are identification of critical illness and care of critical illness. We want to be able to determine critical illness using warning signs and scoring systems. And we want to improve care for critically ill patients through education and training using guidelines, protocols, and cognitive aids. We then want to identify the clinical processes needed for essential emergency and critical care and recognize the components of hospital readiness that are needed for essential emergency and critical care. And then we want to empower our learners to analyze the gap in current institutional resources that are available for critical care versus the ideal implementation of essential emergency and critical care. And we want our learners to be able to implement it in their own institutions. And then finally, we want all of us to be advocates for oxygen and additional EECC resources so we can expand critical care capacity in all of our institutions. And with that, I just want to briefly talk about the oxygen crisis that I think we all are aware is occurring across the globe. This image is from the PATH oxygen crisis. We all recognize oxygen as an essential life-saving resource, but it was only actually deemed an essential medicine in 2017 by the WHO. So this graph shows that for all low and middle income countries, they required 18 million cubic meters of oxygen on this specific day. And that was just to treat COVID-19. That didn't include other respiratory conditions. So we have a huge burden of unmet oxygen need across the globe. Okay, I'm going to outline our case scenario and then turn it over to one of my co-panelists to get started on the first set of practice change objectives. So the setting is that we're working in a rural district hospital. The nearest hospital with an ICU is 40 miles away. The physician working in the emergency room calls you to come see a patient that she wants to admit to the hospital. This is a 66-year-old man with 7 days of dyspnea, dizziness, and diarrhea. He reports feeling weak. His dyspnea is worse with exertion and better with rest. He received the Janssen vaccine 4 weeks ago. His vital signs show a respiratory rate of 27 breaths per minute, a heart rate of 97, blood pressure is 107/59, temperature is 37.5 degrees Celsius, and his pulse oximeter reading, or an SpO2, shows 91% on room air. In the emergency room, he's placed on 3 liters of oxygen therapy by nasal prongs, and his SpO2 improves to 95%. The first set of practice change objectives include exploring acute care, critical care, and intensive care, and listing the domains across which acute care occurs, and then recognizing the critical care continuum. And with that, I will turn it over to my colleague, Dr. Lise, who is the Director of Emergency Anesthesia and Critical Care for the University of Rwanda. Thank you, Lise.
Thank you, Anna. Yeah, so according to the World Health Organization, we would ask ourselves that what is acute care? Acute care is the type of care that happens, like the care you give that is life-saving. So services that are delivered, excuse me. So you give this type of care to change the likely outcome of the patient. This implies like prompt action and the timeliness of the intervention you are giving. So where does acute care happen? So it can happen from the pre-hospital care. It can happen in the emergency room, even on the ward, wherever there is like acute change of the condition of a patient, and we need to intervene to avoid life-threatening or death, losing life or death to that patient. So you need to act quickly and recognize it. Can we move on with the slide? So as I said, this type of acute care will happen at every level, from the pre-hospital up to the hospital to the surgical ward, everywhere. So
So Lise, maybe we can ask the learners this next question. How would you define critical care? Where does it occur? And how does it differ from intensive care? And maybe we could give the learners a few seconds to put some answers in the chat box. So we'll give you about 45 seconds to a minute to define critical care, list where it occurs, and define how it is different from intensive care. So we encourage participants to put their answers in the chat box. We can start with one question at a time, maybe. What is critical care? How do you define critical care?
maybe I can come in. Critical care is part of the acute care. It's like a type of care or medical care you give to a patient that will help to change their outcome. So it means, like, for instance, if I have a patient who requires oxygen or requires intubation, that type of care that I'm going to give, like rather intubation, oxygen, and if I give it in the right time, that can be defined as critical care. So you might give your input.
Yeah, that's great. And also we have some really wonderful answers in the chat box that support your definition of acute care and critical care. So life-saving, preventing death, life-saving. Critical care means treatment given to patients with life-threatening signs and symptoms. Another person says life-threatening, immediate care needed, emergency care plus intensive care equals critical care. It can occur anywhere in the hospital or anywhere else the situation may arise. So all of that is great. I think one of the key themes that we can pull out of both the definition of acute care and critical care is the stress that it's time sensitive or time critical. And the second part is that it's addresses life-threatening illnesses. So when a patient has a condition that is potentially causing a life-threatening situation. Did you have anything else to add to that, Dr. Lise?
Yeah, I think we are good.
Yeah. So from some of the papers that we have included as resources in this discussion, critical illness should be seen as just one part of a patient's disease trajectory, and how the patient is managed before and after ICU admission has an important role to play in optimizing outcomes. Identifying critical illness early before it reaches a stage where it is life-threatening requires a combination of improved and more frequent or continuous monitoring of at-risk patients, staff training to recognize when a patient is deteriorating, and a system to call for help, and an effective response to that call for help. The patient's continuum after ICU discharge must also be taken into account during their ICU stay, with attempts made to limit the longer-term physical and psychological consequences of critical illness as much as possible. Dr. Lise, when you have a patient that you discharge from the ICU, is their illness over? Is their challenge or struggle with their illness over? Or do you see additional problems that patients face after being in an intensive care unit?
Yeah, so after discharging patients from the intensive care, the illness is not over at all, and it's time to really watch out because it deteriorate again at any time. So that's why you have to have a way of recognizing and identifying the deterioration on time so that you avoid them getting back to your ICU. So the critical care will start from the time they get into the hospital until you are safe enough and confident that they are out of danger, which means they are about to get discharged. So once you discharge them, you really have to keep an eye and identify or look for deterioration, though that's not what you wish, but you look for it and you try to catch it using the tools that are available.
Wonderful. So these statements that we listed here are part of an article that was written in 2019 and found in the Critical Care Journal. The author is Jean-Louis Vincent, who is a very well-known ICU physician and considered an expert by almost everyone who trains in critical care. And so he uses this diagram that I think is good for us to recognize that the old paradigm really separates these physical spaces as different places where care can occur. But if you look at the patient's disease trajectory, that care in all of these places must overlap because they're all connected and they all have influence on the patient's outcome. So even what happens, I think another important point is a lot of people consider critical care or to be ICU care, and they consider it to be very expensive. And if we can actually take good care of patients along this continuum, they may not even end up in the intensive care unit. So we consider the care that they receive on the floor, in the ambulance, in the emergency department, all of that can actually help improve their situation, and that may prevent them from going to an intensive care unit. So it may not be that resource intensive. Would you agree with that, Dr. Lees?
Yes, of course. We don't have to see a critical care as a patient being physically in the ICU. Right. So a child who comes, I like to give you an example, like a child who comes and is dehydrated, is in shock, might not go to the ICU, but he needs some kind of intensive care. If you don't give that rehydration straightforward, and that rehydration might happen by EMS or in the emergency room, if you don't give it on time, then you will end up with a shocky child in renal failure. So you have to be aware that intensive care or critical care is given at every level, and that's why you have to be prepared for it all along the patient journey.
Excellent. Could not agree more. Thank you, Dr. Lees, for sharing your experience. So I want to give another update on our patient. He has no past medical history. He states he's otherwise healthy. He exercises regularly by playing football. In America, we call it soccer, sorry. Past surgical history, he doesn't have any surgeries in the past. He lives alone. He's single. He does occasionally drink alcohol, and he is a non-smoker. He's not currently on any medications. He has no allergies. Do remember that he received the single dose, the Janssen vaccine, which is a single dose vaccine, and he received that 4 weeks ago. On review of systems, he denies hematemesis, melena, or hematochezia. He denies chest pain, and he has said he does not have fever. Because he was having respiratory complaints, the emergency medicine physician ordered a CT of the chest with contrast and bilateral interstitial pneumonitis pattern consistent with SARS-CoV-2 is seen, but there's no pulmonary embolus. There's assessment and plan. You and the emergency department physician decide that the patient is to be admitted to the hospital ward with oxygen therapy, antibiotics for community-acquired pneumonia, and dexamethasone for possible SARS-CoV-2 infection. Further tests and workup are in progress. This is a pretty common case stem, I would say, for many of us these days. And also the plan of admission with oxygen therapy and dexamethasone is also quite common. Adding antibiotics is a source of discussion but it's not uncommon to also start community-acquired pneumonia coverage. So I just want to take a second to go through the critical care and global burden of critical illness in adults. The global burden of critical illness is difficult to define for several reasons. Critical illness cannot be diagnosed with a single test or linked to a single procedure. Critical illness related diagnoses are made using clinical exams and investigations. Often their definitions and criteria are debated and changed, which makes it difficult to quantify the burden of critical illness globally. Although critical illness occurs outside of the intensive care unit, data is usually collected within an ICU. So just as Dr. Lee said that critical care occurs everywhere across the continuum of the patient's disease course, most of our data comes out of the ICU. So this data is incomplete in the highest resource settings and may be absent in lower resource settings. So if you don't have an ICU, you don't have ICU data. And if you're not collecting data outside of the ICU, then you really have no data to help us define the burden of critical illness. Critical illness happens quickly and has high mortality rates, so patients may never present to the ICU. And then settings with more resources record more critical disease burden. So if you're looking for it, you find it. Okay, so we're going to go ask the audience once again to answer this question. Which of the following are considered critical patient care? And we have, you can answer in the chat box, or we also have the poll question that has generated. So if you could answer the question, we'll give you a few minutes, or 1 minute to do that. Which of the following are considered critical patient care? Early recognition, assessment, and decision-making for deteriorating patients. Rapid and timely interventions for patients at risk of clinical decline. Identification of clinical warning signs prior to cardiac or respiratory arrest. Providing expert assistance in response to concerns for a patient's status, or all of the above. Okay, we will stop the poll there. 88% of people, plus a few people in the chat box, said all of the above, which is correct. Every single one of those scenarios is considered critical patient care. Okay, let's keep going to our next set of practice change objectives. We want to define essential, I need to clear my poll. Define essential emergency and critical care. Recognize two key domains of essential emergency and critical care, which is identification of critical illness and care for the critically ill. Determine critical illness using warning signs and scoring systems. And improve care for critically ill patients through education, training, guidelines, and protocols, and the use of cognitive aids. Okay, so I'm going to ask Dr. Tim Baker to lead us through the next couple questions.
Thank you so much, Anna. Nice to see everyone on this call, many names that I recognize. Yes, so I'd like to ask you all whether you think it is true or false that critical care and emergency care require expensive technologies and highly skilled healthcare providers. Once again, you can put answers in the chat box or fill in the poll. So shall we end the polling, Diana?
Yes.
So it seems reasonably split between true and false. 42% say true, 58% say false. That's
And there's
interesting answers.
two trues in the chat box, so that pulls in that direction as well.
Yeah, yeah. I think this shows this is very interesting, and maybe some of it comes down to exactly how we're using these different terminologies, which leads us on to, I think, the next slide concerning essential, emergency, and critical care. So this term has come up in the past few years, designed by a group that I'm working with. And it's a term that is used to try and define the most important, most basic, the kind of first level care for the critically ill patient. So EECC is defined as the care that all critically ill patients should receive in all hospitals in the world. It's therefore a term that can be seen as something connected to the global term of universal health coverage, things that should be available for all humans throughout the world, things that are low cost and appropriate in all settings, and intended for all patients who have these acute and life-threatening illness that we have earlier defined as critical illness, irrespective of their age. So it's for children all the way up to elderly patients, their gender, the underlying diagnosis. It doesn't matter what the condition or illness they have underlying it. The only important thing is they're critically ill. Doesn't matter which medical specialty they are being treated in or their location. As long as they are critically ill, they should be receiving EECC. So to operationalize this, we needed to come up with a set of actions and treatments. So what is included in this EECC, and then the requirements that are needed in the system to provide these. And it's clear that two fundamental domains are needed in order to come up with what's in EECC. The patient needs to be identified. If we don't know which patient is critically ill, we cannot provide the care, and then we need to provide the care. So identification and care. And in order to do these things, to carry out these clinical processes, the hospitals need to be ready. So the hospital needs to have the structures in place, the facilities, the drugs, the equipment, the consumables, and very importantly, the trained staff in place in order to be ready to provide this care.
Dr. Tim, there are still some comments in the chat box, and I think a feeling from most people that EECC is very expensive and maybe cost prohibitive. One person says that it's a challenge, especially in LMIC countries. Can you perhaps share your knowledge about why you think EECC might be more cost effective than most people think at first glance?
So I think one thing we need to think of is around these terms like critical care. So for many of us, I'm an intensive care doctor in my background. For many of us, critical care feels like it should be these very sophisticated, high-tech, expensive care that we provide in an ICU. And what EECC is doing is trying to turn that idea a bit on its head and say, actually, we should think of it in terms of what these patients require in any setting in the world. So, for example, the case study that this presentation is based on, a very sick, critically ill man arriving to a district hospital in a hospital which doesn't have an ICU. This patient is critically ill. And he requires some things that can be provided anywhere. So things like some low flow oxygen, some IV fluids, some identification, the pulse oximeter in order to check his oxygen levels. These things is what is included in EECC. And the idea is that these very low tech, low cost things, if they were in place everywhere and always used in the optimal way, we would save the lives of very, very many acutely ill and critically ill patients.
Thank you. And so if I'm understanding correctly, giving the IV fluids to the sick child, as Dr. Lees explained, or simply making pulse oximetry as part of the scheduled vital signs are things that can improve critical care. Is that correct?
Yes, absolutely. So I think an underlying idea behind this is that we are actually very good as doctors, as nurses, as health systems at providing the definitive care for conditions. We're very good at diagnosing and then choosing the right antibiotic, the right antimalarial, the other things that are required for a mother in labor to do the delivery. These things we are good at, but maybe sometimes what we are not so good at, or what health systems are not so good at, is this life-saving kind of supportive and stabilizing treatments for the ABC care, keeping the airway, the breathing, the circulation stabilized while waiting for these definitive treatments to work. So EECC is an attempt to bring up the quality of this basic supportive life-saving care to be a similar level of care as the rest of the care we are providing.
And that actually supports the things we were discussing in the first section, which is that it's time critical or time sensitive, and that it addresses life threatening. So I think I really love that you and your colleagues have done this work, because I feel like even in high resource settings, and I'm sure Dr. Fred Meem could also corroborate that oftentimes people fail to recognize critically ill patients. And so really identifying critical illness is a great first step. One other thing I want to ask you, Dr. Tim, if you don't mind, is our dear friend Santiago put in the comments that true to the question, and that training matters, and so ICU is very expensive. I think that having sessions like this and knowing that organizations such as the WHO are working on basic emergency and critical care resources, that the training doesn't have to be expensive either. What are your thoughts around training and as a part of EECC?
So I think that's a really good question. I think the idea is that the clinical processes in EECC are simple, because by definition they have to be possible to provide in all hospitals in the world. So we are not thinking of mechanical ventilators providing sophisticated respiratory care. These are simple things, but training is still required. I would see a parallel with CPR training, so basic life support training, which in settings all throughout the world is done as a very rapid kind of refresher course for all health workers, doctors, nurses. Everybody does the same training, and that's for patients then who have already had a cardiac arrest and trying to resuscitate them back to life. I would see a parallel in the future of regular EECC training for all health workers, nurses, doctors, everybody, the same training, teamwork, communication, these basic examples, basic skills in order to try and prevent the patient having the cardiac arrest. So finding the critically ill patients and giving them these basic treatments, actions and treatments before they get so sick that their heart stops beating.
Wonderful. Yeah, I completely agree. Okay, I'm going to move us forward just a bit and we talked about the two key elements or components of EECC being identification of critical illness and care of the critically ill. So this patient is sent to the hospital ward. So our patient that we're discussing, the 66-year-old man with respiratory symptoms and hypoxemia, despite being placed on 3 liters per minute oxygen by nasal cannula, 2 hours later, the patient's SpO2 decreases to 86%. This is an example of identification of critical illness. So what is the clinical problem that's being identified? So you can put that in the chat box. What's the problem? The easy part is to identify the problem, I think. Anyone can answer in the chat box. What is the clinical problem outlined here? At least, what do you see with this update? for this patient? Hypoxia, thank you, respiratory distress. So the patient's SpO2 has decreased to 86% despite receiving the oxygen that we gave him. So this is an example of identification of critical illness. So who is responsible for identifying this problem? What is needed to identify the problem, and what should happen next? So who's responsible for identifying a critically ill patient? I would say everyone. Dr. Bryant, what would you say? Is it the physician? Is it the nurse? Whose responsibility is it?
Completely agree. I think it's the entire care team's responsibility, and a good identification system is one in which it's simple enough that all team members can easily use it and kind of have a way to kind of escalate concerns quickly.
Great. I'm starting to see some great answers in the chat box as well that support what you and I are arguing, that everybody is responsible for identifying patients that are critically ill. I think one key component when we consider places that may or may not have the same systems when equipment is that you have to have a pulse oximeter available. And I think another thing that should be considered is making pulse oximetry one of the vital signs. So not everywhere checks pulse oximetry when they check the heart, the pulse, the breathing, and the blood pressure. So making pulse oximetry part of the vital signs is one way you could improve on recognition or identification of that critically ill patient. And so what should happen next for this patient? Bryant, Dr. Bryant, what do you want to do for this patient?
So I think this person, someone who's going to need to be escalated in terms of their oxygen needs. So essentially give them more oxygen therapy, let the hospitalist or the ICU doctor know that they're putting this person on a lot higher levels of oxygen to escalate their care and figure out where the trajectory is going.
Wonderful. So the patient definitely needs more oxygen, but that patient may also need a higher level of care. So if you're in a district hospital without an ICU, at this point, you should consider calling the senior doctor or the senior nurse and discussing whether this patient can get a higher level of care at that facility or perhaps needs to be considered for transfer. Okay, so the ward nurse calls you. When you arrive, the patient is alert, but appears to be working harder to breathe. He can only speak 2 to 3 words at a time. Now his respirations are 27 breaths per minute. His temperature is the same. His heart rate is 93. Blood pressure is 112/79, and SpO2 is 86. Okay, what is an example of a hospital system that serves to identify deteriorating patients before they become critically ill? So Dr. Bryant, I'm going to let you take this section.
Okay, sounds good. So I see some of the answers rolling in. I see rapid response team. And I think this is an important point if we're talking about tangible things that can be done in both low and middle income countries to provide this concept of critical care throughout. And I think response teams are great answers from a systems perspective. It's something that can be done at a high level hospital with lots of technology or a hospital with very low resources. And it's essentially creating a system in place that all the nurses and physicians around know who to contact and who to escalate things to if there's concerns that the patient is worsening clinically. So here's a statement actually by the Patient Safety Network, an agency for healthcare research and quality. I believe there's a link on the website as well if you want to kind of dive into this further, but it states, patients whose condition deteriorates acutely while hospitalized often exhibit warning signs, such as abnormal vital signs, in the hours before experiencing adverse clinical outcomes. In contrast to standard cardiac arrest or code blue teams, which are summoned only after cardiopulmonary arrest occurs. rapid response teams are designed to intervene during this critical period, usually on patients in general medical or surgical wards.
Which reminds me of what Dr. Tim was just saying, that CPR is a way to train folks to care for someone in cardiac arrest, but wouldn't it be lovely if we trained people to identify early warning signs and perhaps prevent that cardiac arrest from happening in the first place? Wonderful.
Yeah, definitely. I think this is something that we do here at our institution, is kind of identifying patients early to escalate care to, in places that you can be doing in all parts of the world. So if we could have people take a second now and list 3 warning signs that patients may exhibit prior deterioration. If you're thinking about systems, if you're trying to build your own rapid response team at your hospital, what are some suggestions for things to watch out for that you'd want nursing staff and nursing assistants to be aware of?
We have some learners who put in the chat box early warning signs, so now they can list them for us. We have some good answers in the chat box. List 3 early warning signs that patients may exhibit prior to deterioration. Someone says tachycardia, good. Altered mental status, thank you, Santiago. Dyspnea, change in vital signs or mental status, great.
Excellent. Yeah,
what do you think about those answers, Bryant?
I think these are great. I think the low-hanging fruit is certainly vital signs. It's something that's a little bit quantitative that people can objectively obtain, and there's less ambiguity in it. But also, for the bedside nurse, there's things that matter to kind of notice as a change. So I like the ones that mentioned changes in mental status, concerns for work of breathing, unrelieved chest pain, severe pain in general, or decreased urine output is something that I always get concerned about. If patients for the last few hours haven't been voiding as frequently or good volumes. And obviously what we talked about a lot already was the oxygen saturations, the tachypnea, tachycardia, are all things that kind of signal to you this person might not be doing well, especially when you're looking at the trend over time. So these are all great answers that we've been given.
Yeah, I personally agree with the altered mental status or change in mental status as a warning sign. And I think that one is less recognized sometimes than the objective numerical vital signs. Altered mental status or agitation isn't normal, and it's a red flag that something is going on with the patient. And I feel like in some settings, my settings specifically, people will often sedate the patient or try to treat the altered mental status without looking for the underlying etiology or cause of that problem. And so I think framing altered mental status, decreased level of consciousness, agitation, those things really are early warning signs. So I agree with that.
I'd like to think of them all as evidence of end organ damage, and the mental status being the brain, being the end organ, and like the urine output being the kidneys. So some things that are a little bit more subjective can help out a lot.
I see a great question in the chat box, if you don't mind if we answer that before we move on. Are these signs different in children? So what are some early warning signs in children? And I'll ask my co-panelists to help me answer this, but I think in children, they actually become less responsive or listless or have or obtunded. What are some other things that we see in children who are in distress? Dr. Leese, do you have some ideas? I still can't hear you. Sorry, I think you must be muted. That's okay. Okay, what about Dr. Karima? We haven't heard from you yet. We'd love to include you in this conversation. So Dr. Lisa is helping us through the chat box since she's muted. So inability to feed is another one that I thought of as well. Great. Okay, let's move on. Dr. Bryant, what is NEWS 2 and when should it be used? And what is the NEWS 2 score for this patient?
Awesome. Are any of you familiar with the NEWS 2 score, or do you use it in your clinical practice? seen it before. So we actually is not a score that we routinely use here at our institution, but I think the same principles sort of apply to here or anywhere else. And essentially what it is a scoring system that that helps providers determine the degree of illness of a patient and whether or not they warrant immediate critical care interventions. So the important things I think to take away here is where the mouse says it shows sort of when to use. So this is really for patients who are essentially adults, so greater than 16 years old, 17 and up. It's not validated in children or in pregnant patients. And the Royal College of Physicians actually recommends using this score in a number of settings, including the emergency ward, the general ward, and pre-hospital, as a way to sort of triage patients quickly and in a timely way to understand how often they need to be assessed. So it's built in to kind of look at both their respiratory rate as well as whether or not there's any concerns of respiratory failure by looking at the degree of oxygenation that's required to support them into a normal range. It also looks at some of the other things we talked about as well, including fevers, blood pressure, heart rate, as well as their mental status as well. And the thing that's nice about this is it's a very quantitative scoring system that gives you clear recommendations. So someone who doesn't have quite the critical care training can use this if they know how to take vital signs and assess a patient and follow an algorithm for when to escalate care. So what this does is it gives you a scoring system to determine where the patients should be reassessed. So looking at this patient, any thoughts on if whoever's familiar with the News 2 score, what our score would be for this person? So
well,
we have
I can plug it in for us. So his respiratory rate, if I remember, was 27.
Yep.
Does he have risk factors for hypercapnic respiratory failure or retention of CO2? I would say no. He's not a smoker. He doesn't have emphysema. So I would say no. And then his room air or supplemental oxygen SpO2 was low. It was 86, wasn't it?
Mm-hmm.
Room air or supplemental. He's on supplemental because he's got the nasal prongs. And what was his temperature again? 37.5. And his systolic blood pressure was 112. So that's correct. And his heart rate was 93. So we'll go here. And he wasn't confused, was he? He was alert. So we got 9 points on this National Early Warning Score. So what does that mean for us? And this patient, really, what does it mean for our patient?
So when patients start scoring over 8, that's when there's the scoring system indicates that they require an emergent assessment by a critical care team and likely will need to transfer to a higher level of care for that. But these situations are kind of always based on the clinical practice around. That's where the general guidelines for the new 2 scoring scale.
Great. I just want to point out to our learners and participants that this calculator is free and open access on the website mdcalc.com. So you can access that calculator directly. That website has several clinical calculators. It's not just for the News 2, it's for many, many different clinical calculators. We find that to be a very useful resource. So feel free to check it out by going straight to mdcalc.com, or you can actually click on this link for context of the News 2 as on the LRC or the Learning Resource Center. Okay, so we talked about 2 key components of EECC being identification and care. So we're going to talk about care for critical illness. You decide to increase a patient's oxygen therapy by switching to a mask with a reservoir bag, also known as a non-rebreather, and increasing the flow to 15 liters per minute. This is an example of care of critical illness. How do providers know how to give appropriate care? How do we know, how do providers gain the knowledge of how to care for critically ill patients? What are some potential answers? What guides us to make the decisions that we make? Training. What else? Education and training is one thing, but we can also use things such as guidelines, protocols that are developed that are evidence-based and peer-reviewed. We can follow along with some of those. Great. Corinne says guidelines. Reassessment of patient vital signs, right? But we have to have the training and knowledge to know that that's important. Training algorithms, scores, excellent. Wonderful. So I would say education and training is key, in addition to guidelines, protocols, etc. Just to make everyone aware, there is a basic emergency care course that is put out by the WHO. There's another basic ICU course coming out of South Africa. A lot of these courses are free, open access, and online. And the WHO is also in process of creating another critical care course in addition to the basic emergency care course. So these resources are expanding and becoming more available. Again, they're all open access and free online. So here's the link. If you want to go on to the Learning Resource Center, you can click the link and go straight to that basic emergency course. I'd like to also turn your attention to some free open access online resources for guidelines and protocols. The SCCM is the Society of Critical Care Medicine. There's Guidelines Central that talks about guidelines of critical care. CHEST is from the American Thoracic Society. They have several guidelines on critical care topics. The National Institutes of Health has COVID-19 treatment guidelines that are freely accessible. COVIDprotocols.org is a website that we have shared several times throughout our sessions. It's some of our friends and some of our other organizations. Great protocols for treating COVID-19. And then OC2 stands for opencriticalcare.org. And again, an amazing resource library with lots of guidelines and protocols. Someone in the chat, Corinne, is asking, can you share these links with us? These are all available on the Learning Resource Center. If you sign in there, you can access any of these, or you can access them directly online. So Alana, do you mind popping in the LRC's link? Oh, she's all over it, never mind. So Alana will help us out with that. Okay, Dr. Fred Meem, if you don't mind, could you help us answer this next true false question and lead us through the next slide or two? And good morning. Good to see you.
Yeah, good morning. Interesting that to understand that physicians and nurses, people caring for people who are highly stressed, experience their own stress, because we're all human beings and we all respond to highly stressful situations in physiologic ways, and it's not good physiology. It's kind of something we have to overcome and learn how to think clearly during a stressful situation. So the sympathetic response, just to remind you, has been clarified. It isn't just fight or flight, but it's freezing and fainting and being paralyzed. I mean, that is the sympathetic response. And any of us who have been around a while have actually seen people literally seize up and not be able to speak. This is part of what it means to be human when you're overcome with a very stressful situation. So cognitive aids kind of jump in right there when your thoughts are just kind of frozen up. You recognize the emergency situation, and you're a good doctor or a good nurse, and you kind of been trained well, but here it is, you're in the moment, you're in the situation, and a cognitive aid has been developed to actually recognize that sometimes we do need something quick and fast, and we're not talking about a textbook. We don't have time to bury our heads into a textbook and read about something.
Definitely not.
We need something quick and fast. And I couldn't be more proud of some of our physicians at Stanford who have developed this emergency manual that you can see on screen here. And it if you just scroll up, you can see the emergency manual is meant to use in that highly stressful situation. And you can see the front cover of it is actually the table of contents. So you don't waste any time getting right to the event that you're dealing with. And I think, do we have the slide showing just one example of this, just to give you a handle on how this is laid out?
Yeah, so I'm happy to do that, Dr. Main. So we have several scenarios that are common emergencies. Which one would you like to review?
Well, let's just look at bronchospasm, because that's
Okay.
That can be a very sudden event. It can happen immediately after intubating a patient, and all of a sudden you didn't have the problem, and now you've got it, and it can be very serious. So it's a single page. If you can flip to that, can you get to that?
Yeah, I was actually trying to go straight to that page. I'm not sure. So I maybe we should just point out, and then I'll go straight to that page, that that it's available in multiple different languages, and that it's free to download the manual. So let's see if we can do that in real time. Download the English manual, since we're
just to prove that it is actually that easy. Oh, you have to put in some data there.
You do. Let me find it somewhere else in the meantime, but
I can get it pretty fast, I think, here as well. Let's see who gets it faster.
I know I have it on my desktop. Hold on,
I'm going to stop sharing.
Yeah, I'm going to stop sharing briefly and I'll pull it up, but
okay. I've got it on my desktop if you don't.
Oh, go ahead and screen share then. Perfect.
All right. Let's go ahead and do that. And I'm going to do that. Share that. So what we're looking at now is just a page. It's very concise. It's a page on bronchospasm. You have bronchospasm. You've got a couple ideas in your head. You want to be sure that you're not missing anything. So you're just glancing at this. And I love the color coding as well. So the red here are the signs of the problem. Do you have these problems? To confirm that you actually do have bronchospasm. There are hints here about whether you want to call for help or not, inform the team, other people that may be right there about what you recognize the problem to be. And then in blue, there's a very clear statement about how severe bronchospastic patients can develop some other problem that is very distracting, meaning the patients who have severe bronchospasm, especially if they're getting positive pressure ventilation, can develop hypotension because of air trapping and decreased venous return to the heart. And if that happens, now you're trying to treat the hypotension with fluids or pressors or whatever, but the real problem is the respiratory condition. And in the lighter color at the bottom, highlighted treatment, there are these things. Again, I love the idea of a cognitive aid is to be simple, straightforward, no discussion, just bang, bang, bang. This is what you need to think about doing. And while you're going to get perhaps some beta-2 agonists, notice here that it's reminding you that the patient needs to be on 100% oxygen. And if you don't give the patient enough exhalation time, which is what we're referring to here in this IE ratio, they won't be able to prevent or you won't be able to treat the air trapping that's occurring. You have to let them exhale. It's like allowing venous return to come back to the heart because the pressures in the chest are decreasing by giving them more exhalation time.
But if you're the primary provider, are you the one reading this, or how would you use this in a clinical situation?
Well, absolutely. The primary provider doesn't have to be doing this. If you know a couple things that you need to be busy doing, you may not want to divert your eyes from the patient. So having someone else grab it, a nurse grab it, and just read as you're treating the patient and doing the things that you know you need to do to either to investigate further or to actually start treatment. Someone else can just read these things very quickly and remind you of those things that you might forget in the moment, because again, highly stressful situation. And also, by the way, extremely satisfying when you actually intervene and you see the patient get better right in front of your eyes. This is the huge personal satisfaction you have of treating patients who are truly critically ill and doing something important, because you're right there and you see them get better.
This is great. So when we go back to this true false question, when we are in the stress of a critical event, physicians are more likely to implement all known best practices optimally. So that answer would be false, because stress affects, critical illness causes stress to the patient and the provider. And so all these other scenarios are also really important. Dr. Amin, have you used any of these scenarios in real life when taking care of your patients?
Yes, I have, and I think I think you have to get over one thing I will mention. I think you have to get over any get past your ego. If you think like looking for a cognitive aid like this is a sign of weakness, or you're not well trained because you have to use a cue card. Absolutely, that's just ridiculous thinking, and I would discourage people from thinking this is anything but sharpening your skills. And if you hear someone reading off, someone who's helping, reading off all those tips on this cognitive aid, and you say, yeah, check, 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 I did everything, great, pat yourself on the back, but also pat yourself on the back for checking that you really didn't miss anything. And so I think these things need to be more commonly used, and because they're readily available, I would encourage their widespread use. Notice also on the, if you go down lower, there's also a specific emergency manual made for obstetrics, and covering all the common obstetric problems that also kind of just like jump at you. You know, it wasn't a problem a minute ago, and now it's a problem. And so that suddenness of the patient's deterioration can be, again, highly stressful on the caregivers. And cognitive aids are a real advance in the practice of medicine, in my opinion.
The thing I love about these cognitive aids is not just that they help us take better care of patients, but this team has really tried to include the most common scenarios. They have made these manuals free and open access to all. And they've also are either in many different foreign languages, or they're in the process of being translated to other languages. Dr. Amin, thank you so much for taking us through bronchospasm and the use of cognitive aids. And I agree with you completely that we do, it's not a sign of weakness to call for help and to use the cognitive aid, because it actually makes you deliver better care to your patients. So let's move on to our next set of practice change objectives. List the clinical processes needed to identify and care for critical illness, and recognize the components of hospital readiness needed for EECC, or essential emergency and critical care. And I'm going to ask our experts, both authors on the EECC paper, to kind of walk us through this. And this is Dr. Tim Baker and Dr. Karima Khalid. So Tim, if you are available, we'd love to hear how EEC works in practice and discuss the core components.
Sure, thanks, Anna. So this is a conceptual framework that helps to understand what it is we're trying to do with our patients, and the table below shows the different examples to aid understanding. So if we start actually on the right-hand side there, the red box number 5, this is what we're trying to do. We're trying to get our critically ill patients to survive. And in order to get the patients to survive, we need them to be stabilized. So we need their deranged physiology and their life-threatening critical illness to be stabilized. To get to that stage, we need to provide them with this most basic essential care for their critical illness, which we have called EECC. So we are looking for effective coverage of EECC. And we've already mentioned that EECC has these two domains of identification, which is that box number 1, and essential care, box number 2. If we provide if we identify the patients and provide them with the care, then we will be giving effective coverage. In order to do both of these, identification and care, we need our hospitals to be ready, which is all of the things, the stuff, the staff, the trained staff, the equipment, hospital readiness, to be there in the hospitals. And then we need to use it in the correct way, the clinical practice. So this conceptual framework allows us to understand what it is we are trying to do with our care of critical illness in our patients, and also provides a very useful framework for all of us to do a kind of gap analysis in our health facilities if we think there is a problem, to try and understand where it is. And the table below provides examples of what all of these are, which I think Karima will get to now in a bit more detail. On the next slide, I think.
All right. Thank you so much, Tim and Anna. So in order for us to conceptualize the EECC, as Tim Baker has just introduced the concept to us, we needed also to define the content of what EECC is all about, because it was a new concept that needed more definition. The content in the aspects of EECC are things that we do every day to our patients. Like we've been talking about identification and care, but we needed to have some sort of a package that tells us exactly what we need to do to identify a critically ill patient and what kind of care we need to provide for them that is basic and essential for every critically ill patient to get. So for us to be able to do this, we went through a process, a Delphi consensus process, whereby we invited experts from all over the world, from different specialties. And these were people working in different departments of the hospitals and different cadres, and starting from emergency department to the wards, because we believe critically ill patients can present anywhere in the hospital, especially in the wards, and they need to be identified and cared for. So what we did, we invited these experts from all over the world, and we made sure that at least 50% of these experts had some sort of low and middle income country exposure, so that they're able to understand the context of what it is like in these areas. So the Delphi process had a total of 3 rounds, and we had we started with we were able to reach at least almost 900 experts, and around almost 269 experts participated in the process. And with that, we were able to define the contents of EECC. We are able to come up with the treatment and actions, and eventually with the study group sat down and put this treatment and actions into clinical processes that are used for both identification and care of the critically ill patients. With that, after we were able to define what the clinical processes are, we also needed to define what are the things or the stuff that is needed to be able to provide, to be able to meet these clinical processes, and we call those the hospital readiness requirements. And we developed these hospital readiness requirements, and through a process whereby we did literature search and using the WHO guidelines, other guidelines that are there that are being used in different specialties, and using our clinical experts who are involved in the process of the Delphi to define what is needed for each of the clinical processes to be able to take place. And these were what the requirements were put in different categories, which we had 9 categories, including equipment, consumables, drugs, and the like that were needed for us to be able to provide the care that is needed for these patients. And In total, we had 40 clinical processes that were defined in this process, and we had 67 requirement readiness that were needed for care for provision of the clinical processes. At the same time, in this paper, we also defined the essential diagnosis specific care for critically ill COVID-19 patients. And we, with that, we had an additional of 7 clinical processes and 9 hospital readiness requirements that are needed, other than just the EECC, that are more specific to patients who had COVID-19. Yeah, that is, I think I can hand it over back to Tim now to explain to us more about the clinical processes.
Great, thanks so much, Karima. So as all of the learners will see, this is really not rocket science. None of these things are new for anybody. The innovative thing or the useful thing is that they are now kind of defined and specified by this very large group of experts throughout the world, and they are contained in these lists. So they are now become a useful tool for all of us to use for the care of our patients and for the improvement of care practices. So I think I will not go through bit by bit on these. All of these are available in the article, which is online, and the link is in the chat box. But just to say, these lists in the article are arranged as Karima said. It starts off with the processes, so the things we should be doing for our patients, a list of these clinical processes, and it starts with the first domain, which is identification. So of course, the hospital should use vital signs-based triage, and it says which are the vital signs that the global group thought were the most important ones, and then it specifies when these should be done. And also just to remind everyone at this stage, this is the attempt to define the minimum standards. So for example, it says there the vital signs should be checked at least every 24 hours. The idea is that any hospital which is able to do more than that, fantastic. All facilities should begin with ECC, and if they have more resources, more staff, more availability, please increase above ECC. So it shouldn't stop here, but it is trying to define the kind of floor, the base level below which no hospital should fall. So those are the beginning of the identification ones.
Interject, sorry, Tim. I think just to support what you're saying, I think it might sound simple, but some places don't have pulse oximeters. So if they don't have pulse oximeters, this can give you the minimal standards of what, one way you could do a gap analysis of your own institution and strive to procure pulse oximetry. And then once you have pulse oximetry, to make it part of your core vital signs. So I think it's excellent to actually just have it written down in a list of what should be happening. So I think it's really wonderful.
Great. So the list is longer than that for identification. You can find the rest on the article. And then the next list, is the one for the clinical processes for the care. So this is arranged in the classic airway, breathing, circulation that we all know so well. And it is just, once again, defining the essential care. So to kind of showing which things should be included. For example, in breathing, it includes optimizing the patient position and providing oxygen therapy using nasal prongs, face mask, or mask with a reservoir bag, a non-rebreathing mask. But which shows that it doesn't include mechanical ventilation, it doesn't include non-invasive ventilation or high flow nasal oxygenation. But of course, once again, if your facility can manage those, wonderful, please go above ECC. This is defining the base level, the first line level. And as well as ABC and reduced conscious level, there's also other care like inserting cannulae and things like that. And that leads us back to Karima to then talk about what things are required in the hospital to provide these clinical processes.
Thank you so much, Tim. So as Tim has just stated, to be able to carry out those clinical processes, which are quite basic, as we have seen that we should be able to provide to all critically ill patients, we need some basic requirements that a hospital should have to be able to provide this care to these patients. And these requirements are so basic, and as you mentioned, a pulse oximeter is one very good example for identification of critical illness that every facility should at least have. And most of the other things that you will see in this list are already available, but they just need to be seen as a package for identifying these critically ill patients. Things like the pulse oximeter, as we just mentioned, in terms of equipment, but also in terms of consumables, we talk about safety stuff like the soaps and examination gloves. We don't need any medication to be able to identify a critically ill patients, but we need human resource that is trained and with some sort of a guide that will help them to be able to identify these patients. And we're talking about very basic training that can be task shifted to even the lowest cadre in a hospital setting. So those people, we can see in our setups that we have nurse assistants running wards, running departments, sometimes taking care of patients. So they just need to be given this basic knowledge so that they're able to safely take care of these patients and identify them when they are critically ill. And once they have identified the patients, they need to be able to provide the care that is needed. And this care that we're talking about is also the very basic care that any hospital staff can be able to provide. And to do that, let's say you have a patient who is hypoxic or maybe is unconscious and has some secretions. What you need to do is just be able to hear those sounds, gargling sounds. You have identified that there's something wrong in the airway, and have a suction machine that you can use it. It doesn't have to be electrical, it can be a manual machine that you can suck this patient and clear their airway. You need to have oxygen that you can provide to this patient who is hypoxic, and the consumables that you would need for that, maybe a face mask or nasal prong that is so basic that should be available in each hospital. And things like for drugs, we need IV fluids that we are able to give to these patients, oral rehydration solutions, basic things like diazepam or adrenaline that are life-saving drugs that need to be in each and every facility. And with that also we have the human resource that is needed, just as in identification and also in the provision of care. We need trained human resource with just the basic training that they need to be, so that can help them provide, like how to give oxygen, how you open the cylinder, how many liters you need to give, and the like. And with that also there needs to be some sort of routines. How do we do this? How do we conduct our everyday activities in our hospitals to be able to provide this type of care to our patients? And of course we need space, so infrastructure to be able to keep these patients. We see that in most areas we try to keep these patients close to the nursing stations where we can see them. We have beds whereby we have few people to take care of patients, so we need this to have a space that is designated for patients who are critically ill in our area. It doesn't have to be a sophisticated ICU or an HDU, but just a space that has all these facilities in it. What's next?
I think general processes, what does that mean?
So with general processes, what we're trying to say here is that these are guiding principles when it comes to how you're going to be providing the clinical processes. You should be, for example, be able to have clear communication with the team that is providing this care, know when you need a further hand to assist you to provide the care, know that when the time has come for you to escalate care by identifying that the problem is not being solved and you need to go up, or or a patient has improved now and you need to go down with the care and stuff like that. So that is more of the general processes that are needed to be able to deliver ECC safely to our patients and efficiently, of course. And there is also some other things that you can use to help you if you have the time to identify patients that are critically ill, that are additional to the processes or the process that we listed in the ECC identification and care area. So these are extra points like cyanosis, capillary refill time, that you can also use to identify a patient who is critically ill. And the things that you talked about in the beginning, like a child who is not able to feed properly, malnutrition, and all those kinds of things. So when you have the time, you've kind of stabilized your patient, and you are able to look at these things in more detail, then you go into more detail and look at assess your patient further and look for these signs also. That would be helpful to you.
Dr. Karima, you said there were additional elements for COVID-19 patients that were identified?
Yes, so we believe all patients who are critically ill need the EECC that we have talked about one way or another, either if they're hypoxic oxygen, if they're in shock, they will need fluids and the like. But we also, since the COVID-19 era, there's also the pandemic is what is hitting all of us right now. So we needed to identify some clinical processes and hospital readiness requirements that are specific to patients who have COVID-19. And we came up with an additional of 7 clinical processes and 9 hospital readiness requirements that are specific to patients who had COVID-19. For example, you needed to the timings of oxygen saturation for these patients, the timing of how often you're going to assess these patients in terms of hypoxia. It has to be more frequent. And there was also things like corticosteroids that are not common to all patients, but they have been proved to be useful in these patients. So those are some of the clinical processes that were additional to COVID-19 patients. And in terms of hospital readiness, we needed face masks that are appropriate to COVID-19, like the N95 masks, or wearing face shields and the like for these patients. And also we needed areas that were isolated for isolating these patients that are separate from other patients. So those are some of the things that are required, that are above the normal EECC for other patients.
Going back to critical illness affecting both the patient and the provider, I think the pandemic and COVID-19 has also caused a lot of stress for providers. So this is helpful to know additional clinical processes that can be put in place to make sure appropriate care is delivered. This work is so excellent. Just to have the minimum standards listed is really helpful, I think, to providers everywhere, regardless of resources. I think it's really amazing work, and I just want to personally thank you two and all of your colleagues that put this together, because I think when we talk about expanding critical care capacity and we talk about improving ICU or the continuum of critical care, it becomes quite overwhelming. So just to have this listed out is really amazing work. So I just want to personally thank you both for everything you've done in this regard. It's really great work.
Thank you.
Before I move on to the next set of practice change objectives, Dr. Tim and Dr. Karima, is there anything else you wanted to add about the clinical processes or identification or care or hospital readiness? Any additional comment?
I guess just to say that it's now out there, it's published. So please, everyone, just feel free to use it. Get in touch with us if you think there's anything we've missed. This can be a process that can be improved and changed over time, but it's there to be used for the gap analyses that we're coming to now and benchmarking of quality and trying to get all our facilities ready and providing the best care we can given the resource limitations we are all struggling with. Thanks so much, Anna.
Right. Yes, of course. Thank you. And Jean-Pierre says that EECC should be introduced and applied everywhere, especially in low and middle income countries. This is helpful. Jean-Pierre, I'm going to send that right back to you, because I think everyone on this webinar, on this call, should take the initiative to improve critical care capacity in their own institutions. And one way to do that is through these next set of practice change objectives. And we can analyze the gap in institutional resources available for critical care. And what does that mean? That means looking at the minimum standards as outlined by EECC and comparing that to current resources, practices, et cetera, within your own institutions. And once you identify that gap, you can then set goals on how to make changes and improve the critical care that your patients receive. So you can implement EECC with the available resources in your own institutions and facilities. And then all of us have a responsibility to advocate for our patients. And one way we can advocate for them is by advocating for oxygen. We're in an oxygen crisis across the globe, especially with the pandemic. But I think the pandemic is really only highlighting the historical neglect that we have had for both oxygen and critical care. So the pandemic is really an opportunity for us to realize that we can do better in these things. So we should all advocate for oxygen and the additional resources for the essential, emergency, and critical care. And so for any one thing within EECC, let's use the example of a pulse oximeter. You can look at the reality versus the best practice or minimal standards is really what we're talking about, and identify the gap. So if you don't have a pulse oximeter, you can try to get a pulse oximeter. If you have pulse oximeters, but they're not being used routinely for vital signs checks, then you can change that. And so by identifying the gap between what's happening now and what should happen, you can also set goals. So identifying institutional gaps for each of the following: identification of critical illness and hospital readiness. Another way to frame this, which I think supports the way EECC has been defined, is to think about staff, stuff, space, and systems. That was an expression coined by Paul Farmer. And if you think about the 4 S's in each one of these things, then you can really identify things, goals that can be improved for these gaps. And then develop an action plan. For each gap that you identify, consider an SBAR or a SWOT analysis for each action plan. And so this is just one example for respiratory distress. There's no standard policy for SpO2. You can include SpO2 in all the vital signs. Vital signs are obtained at regular intervals. Remember, EECC says at least once a day. I think we can do better than that. And especially if our patients are critically ill, we should do better than that and even consider continuous or continual vital signs monitoring. MDs are notified. That's all best practice. And so you can look at the gaps if you don't have a policy on one of these things and then institute it. So best practice, gaps, action items, and then monitoring and evaluation. You want to make sure that the processes that you put in place are monitored for their effectiveness and appropriateness moving forward. So this is just an example, but one way you could take action yourself, Jean-Pierre, or anyone within their own institutions. An SBAR is another way of framing it. You can talk about the situation, the background, do an assessment and a recommendation. Another analysis type is a SWOT analysis, which identifies strengths, weaknesses, opportunities, and threats. I think no matter what, it's really important to involve all the stakeholders that are part of these processes to make sure that they weigh in so that you can identify barriers that other people may see that you may not. So with that, I want to just review our practice change objectives and thank our panelists. I think everyone is just a wonderful, wonderful contribution to this discussion of essential, emergency, and critical care. I think we did a good job, thanks to Dr. Leese, of defining acute care, critical care, and intensive care, recognizing the big takeaways is that it's time critical, and it does help to prevent life-threatening conditions, listing the domains across which acute care occurs. That can be surgery, it could be emergency medicine, it could be obstetrics, it could be pediatrics. It really occurs anywhere and for any type of patient. Exploring the critical care continuum is a reminder that critical care can happen even pre-hospital or after the patient is discharged, and it doesn't just include the intensive care. Defining the essential emergency and critical care. Super grateful to Dr. Tim and Dr. Karima for being part of this and really sharing their knowledge and experience, as well as the global consensus of experts that gave us EECC. Remembering the two key domains of EECC is identification of critical illness and care of critically ill. Thanks to Dr. Bryant for helping us discuss warning signs and scoring systems. And then Dr. Meem for sharing with us cognitive aids and other resources for training, guidelines and policies and protocols. And now it's up to you to implement EECC with the available resources and advocate for oxygen and additional EECC resources in your own institutions. And our quote for this session is, do what you can, where you are, with what you have. So with that concludes our session. Remarkably, it's probably the first time we've ever been on time. We usually run over, which is great considering the amount of material that we discussed. Just to go back to our case, that was adapted from a real case of a patient who contracted COVID-19 after receiving vaccination. So just know that vaccines, even though they are great anywhere from 70 to 90% effective, that doesn't mean that 100% of people will be protected. So with that, I'll turn it back over to Assist International. And again, thank you so much to all of our panelists, and thank you to all of our learners who make this possible and share in all the great discussions.